Hello friends, myself Dr. Parth Goswami, and in this part 2 of pneumonia we will discuss about the morphology of community acquired pneumonia. So we will focus on the morphology, most important short note. Now first of all, what do we mean by CAP? So community acquired pneumonia means pneumonia in the patient living in the community. So patient acquired pneumonia while living in the community, that is a community acquired pneumonia. Risk factor we have already discussed in our previous video, but still some of the important risk factor for the community acquired pneumonia is old age, then chronic disease like that of chronic obstructive pulmonary disease, then congestive heart failure and diabetes, then immunodeficiency, also one of the risk factor for development of community acquired pneumonia, immunodeficiency. Then splenectomy. If the spleen of the patient is removed, either it is automatically removed in the sickle cell anemia or operation has been done. In any case, if spleen is not present, then there are more chances of development of pneumonia by capsulated bacteria. Other causes are the same as like that of our previous video. So see the part 1 of pneumonia first to better understand the etiology of pneumonia. We will focus mainly on the morphology of pneumonia in this particular session. Right? Alright. Now friends, community acquired basically divided into lobar pneumonia or bronchopneumonia. That is the classification according to the anatomical region involved. Alright. So let's begin with what is lobar pneumonia and what do we mean by bronchopneumonia. So friends, suppose if the inflammation of lung parenchyma and the consolidation involve a large area of a whole lobe, or a large area of lobe. So if by the inflammation large area of lobe or the whole lobe is involved, then it is known by the name lobar pneumonia, which can be evident in this particular diagram. This is from the Robbins pathology book. This image is from Robbins pathology book. So this is the lobar pneumonia, whole lobe is involved. But friends, suppose if the inflammation or the consolidation is focal, if there is a patchy scattered focus of consolidation in the same or different lobe, if patchy scattered focus is present, if the patchy scattered foci of consolidation is present in the same or different lobe, then it is known by the name bronchopneumonia. Means the whole lobe is not involved. There is a patchy focus of involvement, which can be evident in this diagram. It is known by the name bronchopneumonia. Alright. So this is the two broad category of the pneumonia, lobar pneumonia or bronchopneumonia. I have discussed the classification in my previous lecture as well. So this is the bronchopneumonia. Laennec scientist has divided the morphological changes in the pneumonia, particularly in the lobar pneumonia, into a 4 inflammatory stage. So there are basically 4 inflammatory response, or we can say 4 stage of lobar pneumonia morphologically. Right? According to the Laennec, there is a 4 morphological stages of lobar pneumonia. This is a very important short note, very important for exam point of view. So understand it in with a focus, statue to the till the end of the video. However, you need to remember that all the 4 inflammatory stage, all the 4 classical stage not seen nowadays. I will discuss which are the 4 stages, but these 4 classical stage may not be seen in every individual nowadays, because nowadays early antibiotic treatment is given, and there is a lots of improvement in the medical care. Because of these 2 reasons, the 4 classical stage not seen in every individual. But let's understand the 4 stage one by one. First one is stage of congestion. Obviously, congestion is the first stage of any inflammation. So grossly, if you observe, then lung is very large, heavy, and the red color. It is boggy red color. That is the stage of congestion. This diagram is from the Hirschmohan pathology book. So as you can see in the diagram, lungs are heavy, boggy and the red color. And if you cut the lung, then on cut open, the blood stained frothy fluid will comes out. That is the stage of congestion. The name is given because the lungs are congested in this stage and it will remain for 1 to 2 days. It is the initial stage. Alright. Now, in the stage of congestion, if you do the biopsy, then microscopically or in the autopsy, nowadays biopsy is not done for pneumonia, but in the autopsy, you might have observed that microscopically, in the stage of congestion, there is a dilatation and the congestion of capillaries of the alveolar wall. So as per the name of stage of congestion, there will be dilatation and congestion of alveolar capillaries, which can be seen in this diagram. You can see a congested capillaries. These are the congested capillaries, alright, of the alveolar wall. Okay. Second thing is that in the stage of congestion, you will observe the RBCs as well as neutrophil. As you can see in this diagram, in the alveoli, the red blood cells and neutrophil can be observed. Follow the arrow. You can see your neutrophils and the red blood cell. Alright. And third important microscopic finding is that there will be pale eosinophilic edema fluid in the airspace. There will be pale eosinophilic pinkish color edematous fluid in the airspace, which can be seen in this diagram. Right? You can see a pinkish edematous fluid in the alveoli airspace. Now, second stage of Lobar pneumonia is a stage of red hepatization. So grossly, in this particular stage, lungs are red, firm and consolidated. The lungs were red in the first stage also in the congestion, but here the lungs are firm, and on the cut surface, lung consistency of the affected lobe is very firm like that of liver. That's why the name hepatization is given. Red means congestion and hepatization means firm. So the lung consistency of affected lobe is liver like firm. That's why the name hepatization is given. And the firmness in the lung is due to filling of the alveoli by lots of exudates and red blood cell. Right? Alright. And on cut open, the lung is red, granular and firm. It looks like an liver. Consistency is very firm. And serofibrinous pleurisy also observed. Alright. And this particular stage lasts for 2 to 4 days. If you do microscopy of the red hepatization stage, then microscopically the edema fluid will be replaced by fibrin. In the first stage, if you remember, the alveoli filled with pinkish edema fluid. Now it is replaced by fibrin. So fibrin strands can be seen in this diagram. Alright. Second change is that there will be lots of exudates, lots of neutrophils and the red blood cell in the alveoli. In the first stage, it was not many neutrophil and RBC. Here you can see a lots of RBC and the neutrophils. Follow the arrow. That's why the hepatization, firmness of the lung occurred. Alright. And alveolar septa is a less prominent in this particular stage of red hepatization. Now, what is the function of neutrophil here? So obviously a neutrophil will do the function of phagocytosis. They will ingest the bacteria, they will do the phagocytosis and they will kill the bacteria. That's why there is a lots of neutrophil to remove the bacteria. Alright. Third stage is stage of grey hepatization. So grossly, on cut open, the lungs are very firm, dry and the grey color. That's why the name grey hepatization is given. Lungs are not red. And the appearance is granular. And obviously the consistency is liver-like. So on cut open, firm, dry, grey color, granular lung is present with liver-like consistency. So because of gray color, they are given the name gray hepatization. The lungs are firm and gray colored. Fibrinous pleurisy is present. Alright. If you do the microscopy, then in the gray hepatization, there will be a dense fibrin deposition. That's why the gray color develop. Here there is a lots of fibrin. You can see a lots of fibrin in this diagram. Alright. Now the red blood cell and the neutrophils in the previous stage will be gradually disintegrated and gradually it will be replaced by macrophage. So here the macrophage cells will begin to appear. In our body, whenever 4 to 5 days pass, the acute inflammatory cell replaced by chronic inflammatory cell. So gradually macrophage start accumulating, which you can see in this diagram. You can see a macrophage. So macrophage will appear. Alright. Now in the gray hepatization, there will be clear space formation between the alveolar wall and the exudate. That is because of fibrin contraction. Because of contraction of fibrin, there will be formation of clear space between the alveolar wall and the exudate. You can clearly see in this diagram that there is a clear space between the exudate and alveolar wall. You can see a clear space. Follow the arrow. You can see a clear space between the alveolar wall and exudate. That is because of fibrin contraction. And this gray hepatization stage lasts for 5 to 7 days. Alright. Now fourth final stage of pneumonia is a resolution. Any inflammation usually end by resolution. So the neutrophil, in the previous stage neutrophil was present. They will release the fibrinolytic enzymes. And the neutrophil's fibrinolytic enzyme will do the liquefaction of the solid exudate. The fibrinolytic enzyme will do the liquefaction of solid exudate. So friends, now the lung softening will start. Now the lungs will no more form. They will start to lose their firmness. They will become soft. They will become soft from the center to periphery. Alright. So that is the stage of resolution. It lasts for 1 to 3 weeks. In the microscopically, in the stage of resolution, as we have discussed, lymphocyte and a macrophage are the main cells. Here there is a lots of macrophage, no more neutrophils and RBC. Here there is a presence of only chronic inflammatory cell, which is a macrophage and lymphocyte. And gradually, the deposited fibril will get degraded by the enzymes. As we have discussed, fibrinolytic enzyme degrade the fibrin, so fragmented appearance of fibrin is seen. Fibrinolytic enzyme degrade the fibrin. That's why the fibrin is having fragmented appearance. Alright. Now, the liquefied material will be removed by macrophage and lymphatics mainly. You might have questioned that where liquefied material will be removed, how they will remove. So they will remove by macrophage or lymphatics. They can drain into lymphatics or they will get removed by macrophage. Alright. And this particular stage begin by 8 to 9 days. It's a final stage. It usually begin by 8 to 9 days and completed in 1 to 3 weeks. But you might wonder that if the treatment is given, which is given nowadays, if you give early antibiotics, then resolution begin on third day. In the 3 to 5 days, pneumonia can be cleared. So that is the advantage of giving the antibiotic in the pneumonia. Alright. Now let's discuss the morphology of bronchopneumonia, where you have the patchy consolidation. So grossly, obviously, patchy consolidation is seen. I have taken all the images from Robbins and Hers Mohan pathology book, That's the image credit to that two book. Very good book for pathology. All right. Grossly, the lungs are red or gray. Form dry and granular because of consolidation. So in the consolidated area, the lungs are gray form, red or gray color form, and dry granular appearance. And the consolidated area is usually patchy of 3 to 4 centimeter in the diameter, and they are slightly elevated over the lung surface. They are slightly elevated over the surface. And such consolidation is often centered around the bronchioles. It is often centered around the bronchioles. So that is about the gross appearance of bronchopneumonia. Here the four classical stages are usually not present. Alright. Now let's see the microscopic appearance of bronchopneumonia. So microscopically, you can see a edema and the congestion. Edema fluid and congestion is present. You can see in this diagram. Alright. Second important thing is that in the bronchopneumonia there will be lots of neutrophilic exudate. As like that of Lobar pneumonia, it is acute inflammation. So obviously you will have neutrophilic exudate. But neutrophil exudate is especially present around the bronchioles and in the bronchioles. So the inflammation of bronchiole is known by the name bronchiolitis. So the bronchioles, you can see in this diagram, bronchioles are filled with neutrophils. So neutrophilic exudate seen in the bronchioles. And in the bronchopneumonia, usually bilateral lower lobe are involved because of tendency of secretion to get accumulated in the lower portion. So bilateral lower lobe involved more commonly. So that was all about the morphology of pneumonia. Now let's discuss some of the aspects of clinical features of pneumonia. So as it is acute inflammation of lung parenchyma, patient is having high degree of fever with a chills. Patient can have cough with expectoration. Patient can have mucopurulent sputum expectoration. Sputum could contain mucus or pus. Especially if Klebsiella infection is present, the expectoration could be difficult. As the lung is inflamed, there will be chest pain. Patient can have difficulty in the breathing because of lung involvement. If you do the chest x-ray for the pneumonia, then it will show a radio opaque consolidation. So x-ray is commonly used for the diagnosis of pneumonia. Patient will have malaise. Patient will not feel well. Patient will feel weakness. Patient appetite is decreased. So all that are features of pneumonia. Alright, now let's see the complication of pneumonia. If treatment is not done, then what will happen? So the first complication of pneumonia is the organization. In the 3% patient, the exudate resolution will not occur. In the 3% patient, exudate resolution will not occur. And in fact, instead of resolution, there will be lots of increase in the granulation tissue because body is trying to heal the inflamed area. Body is trying to heal that area. So the acute inflammation get converted into chronic inflammation, and because of chronic inflammation, lots of granulation tissue, lots of fibroblast will be there, and gradually increase fibroblast in the alveoli lead to alveolar fibrosis. And because of alveolar fibrosis, the affected lobe is shrunken form. That is known by the name organization. And if firmness is very much increased, shrunken form lobe because of alveolar fibrosis is also known by the name carnification. Right? So that is the first complication of pneumonia. Alright. Second complication is pleural effusion. Because inflammation of lung parenchyma can affect the overlying pleura as well. And this pleural effusion is a very common complication of pneumonia, and because of pleural inflammation there will be fluid accumulated in pleura, which is known by the name pleural effusion. So there will be fluid in the pleural space, and usually it is resolved when pneumonia is treated. With resolution of pneumonia, the pleural effusion will automatically get subsided. Now third complication is empyema. Empyema is seen in less than 1% case of pneumonia. That is the third complication. And what do you mean by empyema? So it's a loculated encysted pus in the pleural cavity. It's a loculated, the pus is in the loculated area. So the loculated encysted pus in the pleural cavity is known by the name empyema. The fourth complication, which is very dangerous, is pyothorax. Means pus in the pleural space. Means there will be pus in the pleural space. Means I want to say that there is a pus in the chest cavity. Pyothorax means pus in the chest cavity, mainly it's seen in the area between lung and the inner wall of rib. So the pus is present in the chest cavity, in the area between the lungs and inner wall of rib. Now fifth complication of pneumonia is lung abscess, which is a very rare complication. But in the lung abscess, the name itself suggests there will be lots of tissue destruction and the necrosis of large area of lung. Alright. Now the sixth complication of the pneumonia is a bacterial dissemination. See, in the pneumonia we have the bacterial infection, lobar pneumonia, we have the bacterial infection. But if immunity is low, then sometimes what happen, if the body is not able to eliminate the agent, then it can metastasize to the other organ of our body. The infection can spread to the other organ of our body, like that of cancer cell. So in which organ infection can spread? So it can spread to heart. If it spread to the heart, then it can lead to, if it spread to the heart valve, then it is known by the name endocarditis, means inner layer of heart is involved. If it spread to the pericardium, outer layer of heart, then it is known by the name pericarditis. Infection can spread into meninges as well, which is known by the name meningitis. Infection can spread in the joint as well, which is known by the name arthritis. Infection can spread into the kidney, it can spread into the spleen, and surprisingly it can spread into our middle ear as well, which is known by the name otitis media. So all these secondary infection can develop due to pneumonia, that is known by the name bacterial dissemination. Thanks for watching, and friends, see you soon with the next video, part 3 of pneumonia. Till then, take care and bye bye.